Ladies and gentlemen, the one and only Jason Solis. Good morning, Jason.
Thanks for that, Chris. And good morning to our friend Dr. Kelly Neal, who is joining us from American Medical Center. Doctor, half a day and good morning. So good to see you. All right. And yep, hey, can you bring her? Okay, so I know this morning we are going to talk about. I was emailing you back and forth, and you were good enough to want to talk about palliative care. And I know because when my father was still around, he was a recipient of palliative care, and as one of his caregivers, it was a real educational experience for me to know exactly what that is, what my scope of responsibility is, what resources are out there for people that are in need of palliative care, and maybe more importantly, how palliative care very often gets confused for hospice care. Is that something you find in your profession that a lot of people get backwards or kind of misunderstand?
Oh, absolutely. The lines are blurred all the time. So why don't we start with this? Why don't you tell me what your experience was?
Yes, doctor. as a good medical practitioner,
just start with that one.
Exactly. Well, as a proper medical practitioner, you got to get a good sense of the patient's case, I guess. Well, so my father had a variety of things that he was dealing with, primarily diabetes, and then when it became clear that he was in a renal failure. He was fortunate enough to have a very good social worker who said, okay, well, here's some reading material that you can do. And he also had copies of the reading material for my dad and then for my mom and I, who were his primary caregivers. And then we learned as the months and then ultimately 3 years went by and everything like that, what type of resources there are that private industry provides, that the government provides, that programs like Medicare and Medicaid provide. But then also, like I said, like what my responsibility was as far as doing day-to-day stuff, and then if we would need training or a nurse to come out and everything like that. And then I know because we've interviewed social workers who set people up for hospice care. I actually thought palliative care, I just thought it was something that I personally would have to do and that I would have to get trained in as far as, administering his daily meds, maybe taking blood sugar, blood pressure and all those things and everything like that. But it was a huge educational experience for me. And I would hope that other people would be able to get the kind of education that I did, because it was certainly very, very advantageous too.
Correct. To be honest, are you sure that actually wasn't hospice care?
No, they actually qualified it as palliative. I mean, he was my dad was bedridden at one point. Yeah, but they said it wasn't hospice. He was still going.
Said it wasn't hospice.
Yeah, he was still going to get dialysis 3 times a week.
Okay. So the question is what is the difference between hospice care and palliative care?
Mm-hmm.
Okay.
Yeah.
So once an individual has a chronic condition, and we know that it's not curable. Okay, we're not talking pregnancy here. We're not talking hypertension. We're not talking diabetes. Those things can actually be cured. Okay, so we can, do a lot of things with obesity. We can do a lot of things with hypertension. But when you have end-stage renal failure, we're pretty much, we have a lot of work to do. So we're dealing with the psychosocial, we're dealing with the family, we're dealing with a condition that we're not necessarily going to get out of. We're looking at end-stage renal failure, we're looking at congestive heart failure, we're looking at COPD. These are conditions that we're not going to get out of. So kind of what can we do as providers to bring the family involved, to bring the medical team involved, that involves even the providers, psychosocial, to everything, to a one stop to help the family and the patient deal with the condition. That is palliative care. And it's a beautiful thing to bring all of those resources. Once there is a condition that it's terminal, meaning we have less than 6 months, none of us can predict the weather. I can't predict the weather. We certainly can't predict it here. Once there is a condition that is less than 6 months to live, then there's walk across the bridge. Then we go from palliative care to hospice care. Then we no longer, there's no element of curative. Then goes to hospice. That is the difference from palliative to hospice.
Yeah, and I just found out that, like, when I was actually very surprised at how integrated, let's say, that the program was. Yes, because they said, okay, as his primary caretaker, we're relying on you to perform a certain number of very, very low level, let's just say medical transactions, right? Like, again, administering meds, making sure that elements of hygiene were maintained and everything like that, and obviously keeping his spirits high. But then I wasn't expecting how hands-on the medical professionals would be too. And they were like, they call all the time and just say, how are you guys doing? Are you guys okay? Do you have any? They'd constantly ask me, do you have any questions? And they would also ask me about my state of being, and they were like, are you okay? Are you feeling all stressed out and everything like that? And I kind of liken it, Dr. Kelly, to, how like when you go on a plane and you take that flight, I've always thought it was really odd how the flight attendants always say, okay, well, if in the case the cabin pressure goes low and you're a parent, you want to pull down the pressurized mask and make sure that you mask yourself first and then mask your kids. And I never understood that until it was explained to me by my dad, ironically. And he said, well, because if you're an adult, you want to make sure that you're okay, because if you mask your kid and then you're not okay, then you've got two people who are in real big trouble. So the palliative care, the social worker was always asking me, are you all right? Are you okay? Do you need to take a break? Are you making sure that you at least go out for a walk and make sure that you're all right?
Correct, because you're going to what they call respite. So if you're not healthy, you're not going to be of any help to them, and that's the priority, is that patient. But you're the integral part of that team. So they deal with the psychosocial, they deal with the theological element too. That's what's the spiritual element, what's the financial element, what's the resources that you have, how are their pain element, that holistic, I know that's kind of a big buzzword, but what's the holistic element of that family unit to better take care of mom or dad? Okay, so it's real integral. That is palliative care. And we didn't really necessarily have it until probably the 1970s.
That I did not know. So this were things considered, a terminal case is a terminal case is a terminal case up until that point, or
scattered? I think the better word, it was really scattered.
Okay.
It was like nobody knew who was running the ship.
Okay, you just know you have someone who's in need, someone who's very, very sick, and someone needs to take care of them. Stat.
Yeah, and what they're trying to do is to bring it back so that the patient's centric. Okay, the family is then the next sphere. Okay, we deal with the pain, we deal with the psychosocial, we'll deal with, because again, unfortunately, that condition is not going to go away. So when you said initially in let's take your situation, your family situation, the end-stage renal failure, unfortunately, that's not going to go away. So these are conditions that are not going to just be, they're not going to go away.
And you know what?
So they'll get.
And looking back on it, I actually appreciate, kind of like the candor that you just expressed. And, because my social worker and the nurses that I was very, very fortunate to work with, they were very frank. And they were like, they said, okay, let me tell you, the honest truth and everything like that. This is going to be hard on you. And, he's not going to get better. And you need to realize that. You need to prepare yourself. And then you got to get to work. Your mission is to, and they said the very definition, I believe, right, of palliative care is to minimize suffering and reduce the discomfort that the patient's going through.
Correct. Because there is going to be suffering. So what do we need to do to minimize it? As you said, frankly, because if we don't talk about the pink elephant in the room, when are we going to crack the nut and take care of it?
Right.
We can't shuffle it underneath the rug. And the patient, your family member, knows about it. And if we don't talk about it, it's just going to increase their anxiety. So-and-so is going to know about it, or another family member, and it's not going to help the situation.
Exactly. And I think if I was younger, maybe, I was fortunate that, my dad went through that when I was already in my late 30s and 40s. if I was maybe in my teenage years, I probably would have copped the attitude of just like, oh, I mean, because, you know, my dad for the term of my life, you know, like most sons, my dad's Superman to me. I was like, you know, he's going to get over this. He's going to be able to beat this. But the medical professionals actually addressing me and being very truthful about it and everything like that, that actually gave me the education, but more importantly, the strength to actually do what I needed to do.
Yeah.
And I greatly appreciated that.
Yeah. And it, as unfortunately or fortunately, it was a bridge to then allow what I always call a peaceful passing. It should be a beautiful passing, not one that has a lot of anxiety, not one that all of a sudden was a surprise, not one that is filled with, now, is there going to be grief? Yeah, there's going to be grief, but not one that is going to smack like a train and not going to be one that's not going to be prepared for. Right.
Well, my final question, Dr. Kelly, is in the time that you've been on Guam, since we talked about palliative care, hospice care, and terminal care, in your view and what you've seen from the patients here on island, where do most patients, or where do the majority of the patients, I should say, fall between those three classifications? Are we more palliative? Or are we more hospice?
We're more palliative.
Okay.
On that note, though, I think we have a long way to go. I think we put patients in hospice way too late. I think we need to enroll them a lot sooner. I mean, I think also we have a lot more education to the patients. I think the patients feel like once we enroll into hospice, we're building a pine box in the backyard. It's like, wait a minute, that's not what we're doing. It's a lot. We have a lot more of education in the patients. We can enroll a patient into hospice 6 months before there's an imminent demise. I mean, what we're doing is we're enrolling them in hospice up 2 or 3 weeks before the demise, and that's way, way too late. There's a lot of tapped resources that these patients can benefit from, and they don't have the time to benefit from them. Does that make sense?
Yes, no, absolutely. Yeah.
So many resources. I mean, Catholic Social Services has programs that we can bring for at least 4 hours into the family just for respite care. What I mean by respite care is, let's say the wife needs to go grocery shopping or do just whatever she needs to do, but she's too busy taking care of the husband because she can't leave the husband alone, or vice versa. There's so many resources that are there for them, and they can't be tapped into because they don't know about it. So just talk to your provider to get those resources. The education needs to be out there more, so they need to be tapped into hospice a lot sooner, or to palliative care. And they're just being signed up way too late. Plus, even if there was the demise, Medicare will pay for grief counseling at least a year afterwards, and that's for everyone in the family. And we all know the family is quite large. So there's just a lot more out there.
Well, I consider myself very, very fortunate that I was the recipient of a lot of the education that the Guam system provides and everything like that. So thank you very much for everything that you do for those of us who have that responsibility that we have to go through. And we thank you for your time as always on Tuesday, and we look forward to seeing you next week once more.
Is it? I thought it was Wednesday. Okay.
Well, Tuesday, Wednesday. We appreciate the information you're giving to us. We'll be flexible because you always give us good stuff. So we do appreciate it. Have a wonderful day.
You too. You're welcome.
All right.
Bye-bye.
All right. Bye-bye. And the link will continue, and we've got the Speaker of the Legislature in the Zoom room, and she is coming up right after this.
Catch the